sake of time, we'll move to the next speaker, Dr. Nizar Atallah, استشاري nephrology and transplant nephrologist, a colleague who I work with him on a daily basis, extensive experience in nephrology, and actually he supported us big time during the pandemic for renal replacement therapy, which I think, if you really want to learn a lot about what's happening and what we suffered during the process of COVID-19, I think this is something that you will see a lot on a daily basis with more severe cases, with more patients with COVID-19 and renal failure. Waiting for Dr. Nizar's slides to share. They're there. Dr. Nizar, please go ahead.
Can you hear me?
نعم Dr. Nizar, please go ahead.
السلام عليكم. بدي أشكر الأورجنايزرز للفرصة هذه. دكتور فادي ساد النفرولوجيست بالعادة له دور كبير في الاي سي يو، بالذات في هذا المرض. كثير من المرضى صار عندهم acute kidney injury، ففرصة جيدة نحكي عن هذا الموضوع. بدي أحاول ما أدخل كثير في الديتيلز تبعت الدياليسيس لأن هذه بالعادة needs the knowledge of a nephrologist. But we'll talk as much as possible on the principles and the fluids management، الأشياء اللي ممكن تنعمل to help. So we'll discuss epidemiology of acute kidney injury. We'll discuss AKI in COVID-19 patients. هنتناقش بالgeneral therapeutic principles وgeneral information about the renal replacement therapy. We'll discuss challenges اللي واجهناها بالدياليسيس بالاي سي يو خلال هاي البانديميك. هبلش بكيس. هذا مريض يعني احنا شفناه multiple times، وام شور اي طبيب بيعالج مرضى الكوفيد شوف مرضى مشابه له. 65-year-old male patient, history of diabetes, hypertension, heavy smoking, high risks for COVID. He presented للطوارئ ب 3 days history, cough, fever, loss of taste and smell. طبعا of course كل الأشياء كانت تشير إنه عنده COVID. He did not have any other symptoms. With severe respiratory distress in the ER. He was intubated on the spot and he got admitted to the ICU. كان non-responsive, hypovolemic, he was febrile, hypotensive, tachycardic, high oxygen requirement, chest decreased air entry bilaterally, left lower lung crackles. The remainder of the exam was unremarkable. طبعا labs, standard labs were done. As you see, the creatinine jumped quite a bit, and the الأرقام بالمليgram per deciliter went from 1.2 to 4.1 بالمليمول per liter. 106 to 363, almost 3 times or 4 times. As you see, he was hyperkalemic, acidotic, hyperglycemic. وبعدين بالسي بي سي analysis he was anemic وعنده شوية leukocytosis بس mainly lymphopenia. الاي بي جي صار في discussion امبارح على acid base، بس as you see he had metabolic acidosis, high got metabolic acidosis with lactate type 6. وطبعا nasopharyngeal swab رجع ب positive SARS-CoV-2 PCR. الchest X-ray عند the presentation, as you see, he has some haziness on both sides, more on the left. But within 24 hours, he developed severe ARDS, as you see. طبعا chest X-ray worsened within 24 hours. Ventilator requirement increased to FiO2 of 85%. He needed support with 2 vasopressors. He was prone, became anuric for about 10 hours. When nephrology service were consulted, the creatinine went up to 5.7. Potassium was quite high, 6.5. At that point, we started CRRT, continuous renal replacement therapy. Like in أي مريض بالICU and acute kidney injury, mortality is significant. We talk about 45%. أي مرض all comers. إذا المريض عنده acute kidney injury in the setting of sepsis بالICU, we talk about 70% mortality. This is old data, but still till now almost the same numbers. هذه study looked at about 210,000 patients بالICU and of different stages of sepsis. Early sepsis and incidence of acute kidney injury is about 19%. When you go talk to severe sepsis, بصير في عندك at least one organ failure. Your risk, the incidence goes up to 23%, and when you have septic shock, the incidence goes to about 38-40%. وطبعا mortality increases as you go higher in the stages. Shock was, you had a whole lecture on shock yesterday, but just to simplify it, it's a failure of circulatory system to maintain adequate delivery of oxygen and nutrients, leading to cellular and organ dysfunction. وطبعا acute kidney injury, if you look up acute kidney injury definition, you'll probably find 40 of them on Google. This is a simple definition. It's a functional definition. It's rapid loss of renal function, resulting in retention of nitrogenous and non-nitrogenous waste products excreted by the kidney. طبعا hemodynamic and non-hemodynamic factors contribute to acute kidney injury and sepsis.
Please ask if you can raise your voice a bit لو سمحت.
Okay. هيك أحسن?
Yes, thank you.
We classify acute kidney injury to different stages. In the past, we used to have 5 stages. We call them the Reifel criteria, then we simplified them to 3. So there is risk, injury, and failure. Depending on the level of the creatinine and the urine output, you can classify the patient. Increase by 50% in creatinine is a risk stage, and then injury is double on the creatinine, and failure is 3 times in the creatinine. And the urine output, as you see, if it drops down to less than 0.5 ml per kg per hour for 6 hours, this is risk. And then 12 hours is injury, and then 24 hours or requirement of dialysis is failure. Now, acute kidney injury network is a different classification, but they're close to each other. As you see, there is stage 1, 2, 3, just to simplify it. They added the increase of 0.3 milligram per deciliter in creatinine to stage 1, and they added the requirement of renal replacement therapy to stage 3. Now, when you compare both classifications, whether you look at the Reifel or the acute kidney injury network, they're close to each other in terms of mortality and prediction of ICU stay. So they are interchangeable in a way. The importance of development of acute kidney injury, as I showed earlier, they can predict mortality in the ICU stay. And also there is a risk of development of chronic kidney disease for the people who survive or requirement of dialysis. In the past, a lot of our patients, about 85–90%, will have full recovery after developing acute kidney injury. And some will develop CKD, some will develop significant CKD, and some will end up on dialysis. This is old. Now we're seeing more complex patients. We're seeing more severe illness. So the percentage of patients who develop significant CKD or the dialysis requirement is higher. AKI, as I said, it's a major risk factor for development of chronic kidney disease. The golden hour to diagnose acute kidney injury, it's very important to diagnose it early. It's very important to treat it early, just like any other severe illness. When you look at acute MI, stroke, or trauma, you need to diagnose things early and intervene early. The problem with our disease is that we have limited biomarkers. So we rely mostly on serum creatinine, which usually increases a little bit later. There are other biomarkers that could be available in some places. Cystatin C, urinary NGAL, and KIM1 are the most famous. And you see this is how they behave. Ideally, you need this black line where it goes up very quickly and stays high. As you see, serum creatinine increases late. Then you probably need a combination of other biomarkers to diagnose this. Now, when we move to acute kidney injury in COVID-19, literature shows studies from Italy, China, New York, about 5,700 patients from New York, shows incidence of AKI anywhere between 22 to 25%. Requirement of CRRT was 3 to 4%. This is when you look at all comers, all different levels of COVID-19 patients, symptomatic, asymptomatic, ICU, floor patients. Now, the CRRT requirement goes up to about 10 to 20% depending on the study in ICU patients. And then it goes up to about 39% in patients who are in the ICU requiring mechanical ventilation. Those patients who are in the ICU requiring mechanical ventilation, having acute kidney injury requiring CRRT, their mortality is close to 85%. Also, the New York paper that showed severely ill COVID-19 patients with high SOFA scores in the ICU. Hello?
Go ahead, Nizar. I think somebody was interfering. We can hear you well.
35% of them required CRRT. Now, AKI, this is another study also from New York, different system, about 5,500 patients. About 2,000 of them developed acute kidney injury, as you see, about 1/3. And you see the different stages of AKI. More milder disease, but there is significant also percentage of stage 3 AKI. Of all those patients, 14.3% required renal replacement therapy. And as you have a more severe acute kidney injury, the percentage of mortality is higher. The people who are discharged from the ICU are less, and they stay in the hospital longer period of time. Now, this is when you compare patients who are on mechanical ventilation versus no mechanical ventilation. As you see, people who did not need mechanical ventilation, about 80% of them did not have any AKI. About 20% of them have AKI, and even when they develop AKI, it's usually mild. Most of them are stage 1. Now, people who require mechanical ventilation, much higher percentage of AKI, about 90%, much higher percentage of stage 3 AKI, and the requirement of renal replacement therapy is about a quarter of those patients. Now, AKI mostly happens around the time of intubation, as you see here, and this is, we have more than one theory. Either those patients are really sick, that they required mechanical ventilation, but that affected other organs, including the kidneys, but also mechanical ventilation itself, because of hypoxia, because of hypotension, because of high pressures inside the lung, changes the perfusion pressure to the kidneys, so that increases the risk of acute kidney injury. So whenever possible, to avoid mechanical ventilation, the risk of acute kidney injury will be lower. Now, when you look at univariate, multivariate analysis, just to predict older age are at higher risk, may insist in the univariate analysis. Multivariate did not persist, but as you see, diabetics, hypertensive patients, patients with coronary artery disease, patients on mechanical ventilation, patients on vasoactive medications, all of these are at higher risk to develop acute kidney injury. There are several pathogenic mechanisms of how different organs are affected. Most organs are affected actually in the body. When you look at the kidney, we have acute kidney injury, proteinuria and hematuria develops also. We'll discuss that in a minute. But the pathophysiology in the beginning, it's usually pre-renal because a lot of these patients are hypovolemic, they're hypotensive, you have lower perfusion to the kidneys. Hydrating them is very important. We'll talk about principles of therapy in a minute. Hemodynamic instability, those people are mostly hypotensive, requiring vasopressor medications that lowers the perfusion pressure to the kidneys. Mechanical ventilation, as we discussed earlier. Nephrotoxins, a lot of those patients would have taken nonsteroidals for fever before coming. Also, they were sick, they were not eating or drinking, and some of them would have received antibiotics. A lot of them receive IV contrast in the ER or in the ICU. All of these factors together will contribute to acute kidney injury. And then one important issue is microvascular thrombosis and possible thrombotic microangiopathy. I know there will be discussion in the next lecture about this, but this is very important. It was shown in different biopsies and autopsies. Also, some biopsies and autopsies that were done showed the direct viral involvement in the kidney, especially in the podocytes. And there is also some glomerular diseases that are described, mainly collapsing FSGS. Now, this is a study looking at 3 hospitals in New York. They looked at the period between March 11 and April 26. In that period, they took about 5,500 patients and divided them between COVID positive and COVID negative, as you see on the left. About 1,200 were COVID negative, 3,300 were COVID positive, and compared them with a group around the same period of time, a year earlier, no COVID at the time, about 10,000 patients. And as you see, the incidence of acute kidney injury was higher. Even the people with COVID negative were higher. This is because sicker patients are coming to the hospital. The less sick patients are staying at home, not coming to the hospital. So the incidence of acute kidney injury is even higher with the negative COVID. But as you see with positive, it's much higher. Requirement of renal replacement therapy is much higher. Renal recovery is much less in the COVID patients. Renal replacement dependent is much less because a lot of those people died. So there is competing outcome here. But as you see, COVID really affected the outcome of acute kidney injury in those patients. Now, principles of therapy in general, it's very important to hydrate those patients early resuscitation, and checking the mixed venous oxygen saturation is very important. Of course, when you decide on the IV fluids, probably balanced IV fluids are better than normal saline. The SALT ED study looked at hydrating those patients in the ER. Balanced was a little bit better. Split study was done in the ICU, about 5,000 patients. There was no difference really in terms of AKI outcome. But the SMART study is much bigger studies. About 15,000 patients showed better outcome, trend of lower mortality also. So probably balanced fluids like ringer lactate or plasmalite, depending on what you have, would be probably better than normal saline. Use of vasopressors, as was discussed earlier in other lectures, norepinephrine first, followed by vasopressin. Early sepsis management with antibiotics and monitoring those patients. Control of hyperglycemia is very important. Hyperglycemia by itself can increase the injury to the kidneys and prolong acute kidney injury. And then patients, when they become oliguric, you might want to consider furosemide stress test or Lasix stress test. Moving them from oliguria to non-oliguria can delay the need for dialysis, can also help with the fluid management, and can improve things for the management in the ICU. Of course, correction of acidosis that was discussed yesterday. There is a BICAR ICU study. In general, if the pH is less than 7.2, 7.1 or less, you might want to consider giving bicarb. But if it's more than 7.1, there is no benefit at all. Hyperkalemia management is very important. It delays the need for dialysis because once the patient starts dialysis, their mortality is much higher. You can use different resins, whatever is available in your hospitals. And then renal replacement therapy. Now, one important thing when you think about dialysis in those patients are complex. They have longer exposure. The caregivers who are doing dialysis for them, longer exposure during dialysis. And that might increase the risk for dialysis caregivers, dialysis nurses, dialysis techs. They might need to be exposed. They might need quarantine. They might need to be isolated. That causes shortage of those nurses. So we should have higher threshold for renal replacement therapy initiation, and we should delay it as much as possible. Even studies in sepsis in general, like the Acute study, the START AKI study, showed that early start of dialysis does not give more benefit than late start, as long as there is no uremia or hyperkalemia or severe acidosis. CRRT in general is the preferred modality to deliver renal replacement therapy, but that depends on what you have in your hospitals. I know most hospitals in Jordan do not have CRRT. فالغسيل العادي الهيمودياليسيس ممكن ينعمل طبعا اصعب عمله. بدك الواحد يستخدم اكثر فيزوبريسرز حتى يقدر يعمله، بس intermittent hemodialysis ممكن تنعمل بشكل يومي. In general, the concepts about the dialysis, hemodialysis is diffusive modality. So we rely احنا على difference بالconcentration. جوا الفلتر بين الاختلاف بين البلد والدياليزيت، فالبوتاسيوم كان واليوريا والصوديوم والمغنيسيوم that can move easily according to concentration difference. فعشان هيك we call it diffusive modality. Hemofiltration, which is a convective modality, في bigger pores we apply pressure across the filter, فالwater will move from inside to the outside. وبنفس الوقت مع movement of filter it can move different electrolytes including potassium, sodium, phosphorus. We can play with the concentration لهاي electrolytes كلياتها حسب النوع الغسيل اللي بنستخدمه. In general لما تطلع diffusive clearance بالعادة smaller molecules will come out with diffusive clearance. Convective clearance moves bigger molecules. One of the arguments with the convective therapy, it can remove some of the inflammatory mediators, like TNF alpha, interleukin 1, interleukin 6. It might benefit in sepsis, but at the same time, it's uncertain. There is a relation to endogenous clearance, relation to production rate. برضه في concomitant removal of anti-inflammatory mediators. أنت حتشيل الانفلاماتوري والانتي-inflammatory. فالeffect in general sepsis is not really certain or proven. CRRT, which is the convective modality mostly, it's a slower volume removal, more hemodynamic support. طبعا drug clearance is higher, but you need very good dosage of the drugs. You need a good pharmacist to follow on this. In general, we dose the drugs to GFR of about 25 to 30, في removal of higher molecular weight, including cytokines, like I discussed. هذول different types in general of dialysis. SCUF, we call it slow continuous ultrafiltration. Mainly, it's removing fluid. CVVH is mainly a convective modality, minimal diffusion. CVVHD with SLED are similar to each other. The low efficiency dialysis had a continuous venous hemodialysis. Those are more diffusive modality, but they are continuous, they are slow. طبعا SLED is more efficient. CVVHDF, it's a combination of CVVH and CVVHDF. We call it the Cadillac of all types, but it has diffusion and convection at the same time. And older studies looking at comparison between CRRT and IHD, they were not conclusive, usually imbalanced randomization, they are underpowered, unmeasured delivered dose, high incidence of crossover. فعشان هيك they were not conclusive. There are multiple studies looking. I will discuss only one study in a little bit, but in general, the studies, especially in retrospective analysis, showing إنه المرضى اللي بتعملهم CRRT, the recovery rate a little bit faster. The requirement of dialysis when they recover is less if you compare it مع المرضى اللي بنعملهم hemodialysis عادي. In general, المرضى اللي عندهم hemodynamic instability, عندهم fulminant hepatic failure, acute brain injury, or cerebral edema, they tolerate CRRT much better than intermittent hemo. This is one of the biggest studies that was done to compare hemodialysis versus CRRT, mainly CVV-HDF, also to compare intensity. وهذا يعني they randomized patient حسب شو عندك في المستشفى. إذا عندك hemodialysis you use hemodialysis, عندك CVV-HDF you use that, إذا عندك SLED you use that, and then they compared also the intensity. And the study really did not show a difference whether you use more intensive dialysis versus less intensive, whether you use hemo versus CRRT, there was no difference. Even survival was not different. With dialysis, independence was very close to each other, although CRRT had a little bit trend to better outcome. In general, you need to deliver a good dose of dialysis, and CRRT about 25 ml per kg per hour. If you deliver hemodialysis, you need about 65% of urine reduction to be able to achieve a very good survival. وفيري امبورتنت بالاي سي يو الدليفري اوف ذا دوز، لانه المرضى بنبلشهم على الغسيل، بعدين بيضطروا يروحوا على سي تي سكان، بيضطروا ينعمل لهم عمليه، بيضطروا ينعمل لهم اي بروسيجر بتوقف الغسيل. We should make sure that the dose that's ordered is delivered to be able to achieve good survival. Peritoneal dialysis is another thing. In some hospitals ما في hemodialysis، ما في CRRT, they only have peritoneal dialysis. It's studied against CRRT. It's less effective. But there is more glucose load with peritoneal dialysis, higher infection rate. Volume management is harder. برضه increase intra-abdominal pressure might prolong ventilation, might cause ARDS. What's very difficult to do in prone patients, but at the same time, this is what you have, this is what you need to do. Especially in this time, especially in third world countries like in Africa and South America, a lot of hospitals are using PD because they don't have any other modality. To start a new CRRT program during COVID, it's highly unadvisable because it's very complicated. You need physician training, you need nurses training, policies and protocols need to be put in place. You need to decide on the anticoagulation. If you don't have it before COVID, you should not start it during COVID. Bardo, another important issue is the anticoagulation. There will be a lecture about that, but citrate we use quite a bit during CRRT. Citrate affects calcium, which is part of all pathways of the clotting cascade. If you compare heparin versus citrate, in general, the circuit survival is better with citrate. The major bleeding is much less. There is always a concern about metabolic alkalosis, but the studies really showed no difference between both. And then, of course, hypocalcemia is more with citrate because it binds calcium, it precipitates. You have to replace calcium. You have to monitor that very closely. And HIT, there is a trend of less HIT when you use citrate versus heparin. Now, of course, that depends إذا هذا موجود عندك بالمستشفى ولا لا. مستشفيات كثير بتستخدم الستريت، بس مستشفيات برضه كثير بتعتمد على الهيبرين لحاله. هلا when you choose renal replacement therapy كل واحد له فوائده، كل واحد له سيئاته. CRRT in general عندك continuous removal of solids, continuous ultrafiltration. It's easier على المريض especially إذا كان hemodynamically unstable. عندك central line، في عندك extra lumen تقدر تستخدمه لأدوية ثانية، بس of course في عندك limited number of machines. في supply shortages، في shortage of ICU staff. Availability مش موجود في كل محل. Anticoagulation is very important. Similar thing for SLED. Hemodialysis is more available. It can be done daily. You can manage. بس إذا المرضى really hemodynamically unstable, you need a lot of vasopressor usage, and it might affect the outcome of the patient. طبعا you need portable RO. Same problem, limited number of machines. PD is continuous or intermittent. You need لازم يكون عندك ممرضين بيقدروا يعملوا البي دي nurses. Also surgeons, they need to be comfortable to be able to put a PD catheter لمريض بالاي سي يو على high oxygen requirement. فكل واحد له فوائده له سيئاته. لما الواحد بده يقرر شو بده يعمل بيعتمد على ايش عنده في المستشفى. هلا challenges number of patients requiring dialysis increase quickly usually during the waves. هذه واحدة من الأشياء اللي واجهناها. The ICU beds were expanded very quickly, almost more than doubled in our hospital. والdialysis connections مش موجودة بكل غرفة. هاي كلها أشياء الواحد لازم يطلع عليها لما بده يعمل يخطط لشو بده يعمل بالدياليسيس. طبعا shortage of caregivers، ما في enough dialysis nurses. احنا في المستشفى عملنا باك اب بلانز لICU nurses، علمناهم على الدياليسيس بحيث انه اذا احتاجناهم. frequent clotting انا ححكي عن الموضوع اكثر شوي بعد دقيقتين. وavailability of replacement fluid، هاي كمان شغله واجهناها، اعطيكم شويه ارقام بعد شوي واجهناها بمستشفانا. في طرق الواحد يتغلب عليها. what did we do؟ احنا بالنسبه لنا على اساس واجهنا مرضى كثير بشكل مفاجئ. عدد المرضى اللي يحتاجوا غسيل تقريبا دبل within a very short period of time. صرنا نعمل daily morning huddle بين النفرولوجي تيم، نحاول نقرر مين المرضى بيحتاجوا ومين المرضى ممكن نوقف الغسيل لانه عدد الماشينز كان محدود. كان نعمل ongoing discussion كل يوم مع كل الاي سي يو physicians اللي بيتابعوا المرضى، نحاول نخفف من احتياج السي ار تي ومين ممكن المرضى نحولهم من سي ار تي لهيمودياليسيس. وبعدين حاولنا نجيب ماشينز زياده، كان شويه restrictions لان الكومبانيز كان عندهم huge demand everywhere. وطبعا كان continuous discussion مع الكلينيكال انجينيرنج مع الاي سي يو نيرسز educator، يحاولوا يعملوا ريفرشر كورسز للنيرسز عشان اليوزر ايرورز تخف ونقدر نستخدم الماشينز باطول فتره ممكنه، نقدر نستخدم الفلترز باطول فتره ممكنه عشان يعني ماكسمايز الافكتفنس او الماشينز اللي كنا نستخدمها. بنفس الوقت we introduce SLED او PERT، تقدر تستخدم الريجولر هيمودياليسيس ماشين تعمل SLED. شويه موديفيكيشن خفيف في السوفت وير، اي شركه بتقدر تعمل هذا الموضوع. تقدر الواحد يعمل prolonged treatment 8 to 12 hours، تقدر تحصل نتائج زي السي ار تي. وبنفس الوقت لانه صار في عندنا شورتج للسي ار تي ماشين، صرنا نعمل بدل ما نعمل 24 اور او 48 hours dialysis، صرنا نعمل 12 hours بهاير دوزج، وبنفس الوقت نستخدم الماشين لمريض ثاني على اساس نقدر انه تو ماكسمايز اليوز تبعت الماشين. شغله كثير مهمه كانت بالنسبه لنا هي الكلوتينج. خلال بالعاده بنستخدم هيبرين او ستريت at certain doses، بس مع الكوفيد is very hypercoagulable and thromboembolic. next lecture we'll talk about that. بس كان شغله مهمه كثير بالدياليسيس انه كثير كلوتينج كان يحصل. هذا واحده من البروتوكولز اللي published how to manage this, how to increase anticoagulation to be able to do good dialysis. كثير مستشفيات حولت للسيستميك هيبرين، المرضى صاروا يستخدموا سيستميك هيبرين بدل الهيبرين اللي على الماشين عشان يقدروا يكملوا في الغسيل. هذه بعض النتائج اللي كانت عندنا لساتها unpublished data، بس طلعنا على 3 periods. البيريد الاولى بجانيوري لفبراير ما كان عندنا مرضى كوفيد في المستشفى، طلعنا حوالي 67 patients. النمبر اوف سي ار تي دايز كانوا حوالي 536 patients. طلع الافريج فلتر لايف كان 46 hours تقريبا. البيريد الثاني طلعنا عليها اول ما صار عندنا الكوفيد يزيد في المستشفى من ابريل 1st لماي 8 23 patients 489 CRRT days dropped significantly الفلتر لايف من الكلوتنج اللي صار ل about 16 hours. غيرنا البروتوكول بشكل كامل، سنستخدم سيستميك هيبرين اكثر، علينا الدوزز تبعت الهيبرين، سنستخدم الستريت بشكل اكبر. طلعنا على البيريد الثالث اللي بعد ما غيرنا البروتوكولز تبعتنا 24 patient 459 days عاودت الفلتر لايف ارتفعت بشكل جيد. جود انتيكواجوليشن بيقدر يطول الدياليسيس، يطول الفلتر لايف ويحسن السرفايفل تبع المرضى. شغله ثانيه واجهناها وحيواجهها الكل هو الريبليسمنت سولوشنز، سواء بيعمل هيمودياليسيس واحد سواء بيعمل السي ار ار تي. لما المرضى هذول بصير عندهم هايبر كاليميا بشكل عالي بدك تستخدم لو بوتاسيوم فلويدز، فبصير شورتج. طلع هون مقارنه احنا على مستشفانا بريزماسول 2 هذه لو بوتاسيوم، بريزماسول 4 نورمال بوتاسيوم تقريبا. فبفبراير قبل الكوفيد كنا 490 باجز اون افريج، كل باج حوالي 5 لترز اون افريج. ان فبراير بماي تطلع اولموست تريبلد. بريزماسول 4 اولموست ذا سيم نمبر. فوكسيليوم هذا في شويه بريباريشن مختلف اولموست دبلد كمان. فبصير عندنا كان مشكله كبيره بالسبلاي تشين، احنا عندنا بريدكشنز قديش عندنا مانثلي يوسج، فسدنلي وي تريبلد اور يوز. فصار سبلاي تشين they were fighting to get more fluids، وطبعا في international shortage. فبعض الاشياء اللي عملناها صرنا نعمل ميكسينج للريبليسمنت فلويد، بدل ما نعمل كله بريزماسول 2 ننزل بوتاسيوم كثير، صرنا نعمل ميكسينج بين بريزماسول 2 وبريزماسول 4، ننزل البوتاسيوم لدرجات اقل بس نقدر نستخدم الفلويدز بشكل اطول. هذه اخر سلايد اظن. في أشياء coming in the future. هذه it was approved for emergency use under study في شيء اسمه cytosol technology. زي ما حكيت في الأول، إذا بتقدر to remove the pro-inflammatory markers بالsorbent technology, you can lower the inflammatory storm that happens with COVID patients. فهذه it's under study, بس it's approved for emergency use at least in the United States. Oxirius is a special filter بيستخدم بالCRRT، بيقدر يعمل تقريبا نفس الشيء على نفس جهاز الCRRT. بيستخدم هذا الفلتر بيعمل absorption للبرو-inflammatory markers، وبنفس الوقت بيقدر يخفف من inflammatory storm. برضه it's approved for emergency use in the US. It's approved already in Europe, complete approval. Plasmapheresis is under study also. في عندك special kit برضه ممكن تستخدم to remove the pro-inflammatory markers. كلها هاي التكنولوجيز بقدر الواحد يستخدمها للمريض يصير عنده inflammatory storm. ما بالهيك ما بتفرق يعني regular dialysis أو CRRT ممكن يكون كافية بالنسبة له. بس هاي شغلات ممكن تسمع عنها وتقرأ عنها بالstudies as this COVID problem continues. آخر slide, the take-home message: patients with multiple comorbidities may develop multi-organ failure when acquiring COVID-19 infection, including the kidney. Those patients will require ICU care and mechanical ventilation. AKI increases mortality and prolongs ICU stay in those patients. Different renal replacement therapy modalities can be used. كله بيعتمد على إيش موجود عندك بالمستشفى. احسن موداليتي هي الموداليتي اللي انت متعود عليها، واللي كل الستاف بالاي سي يو والنيرسز متعودين عليها. هذه بتعطيك احسن اوتكمز بالمستشفى اللي انت فيها. In general, if you have the choice, CRRT is better than hemodialysis. Pay attention to anticoagulation، شغله كثير مهمه. هذا المرض بيعمل كثير thromboembolism especially بالdialysis filters، بيأثر على الاوتكم تبع الدياليسيس، بيأثر على الاوتكم تبع المرضى. Wise use of resources and protection of other caregivers very very important. الدياليسيس nurses والاي nurses اللي هم اللي بيعملوا الدياليسيس والCRRT هيكونوا in direct contact مع المرضى، فكثير مهم الواحد ينتبه لهم. في كثير ideas بتنعمل في هذا الموضوع. It's not the place to discuss، بس في extensions ممكن تنعمل. ممكن الماشين كلها تطلع برا الغرفة ويقدر الواحد to manage وهي الماشين برا الغرفة. طبعا it's tricky, it's more complicated, it needs more training. بس في أشياء ممكن تنعمل عشان تحمي ال ICU staff والنيرسز من الexposure لل COVID patients. I think I'll finish with that.
Thank you so much, Dr. Nizar. Amazing presentation, and I think the valid points is, if you can comment on the recurrent thrombosis that you faced during your COVID-19 treatment of dialysis patient. I think that was a very challenging situation. I'm sure the team would have just maybe a 30-second discussion about this challenge you had on patient on dialysis with clotting.
يعني هذه مشكلة it's well described هلا in the literature all over the world. ما في مستشفى عندها مرضى كوفيد كثير بالاي سي يو الا بواجهوا نفس المشكلة. انوصفت بالصين، انوصفت في ايطاليا، انوصفت في امريكا، انوصفت معظم دول العالم. COVID-19 is hypercoagulable state. It increases the risk of thrombosis, especially microthrombi can happen, especially بالdialysis filters. بنشوفها لانه الفلو جوا الدياليسيس فلترز از سلور بشكل عام، فالانسيدنس اوف ثرومبوسيس اعلى. معظم المرضى مش حينفع لهم الريجونال هيبرين. معظم المرضى انه نعطيهم هيبرين خلال جهاز الغسيل ما بكفي. معظم المرضى بحاجه اما لسيستميك هيبرين، والهيبرين اللي بنستخدمه تقريبا زي الدي في تي بروتوكول. وي تارجت هاير بي تي تيز تقريبا 60 to 80 بي تي تي، حتى ببعض الأحيان we go higher. إذا المستشفى عندها citrate option they use citrate. في أكثر من مستشفى في أمريكا they publish protocols they combining both حتى citrate مع heparin بنفس الوقت. طبعا much higher anticoagulation. It's much more trickier, more complicated. You need a lot of training to do something like this. بس it's giving excellent results. بس يعني to make it simple يعني ما بعرف إذا حتى الcitrate موجود في الأردن. heparin to give systemic IV heparin, target higher PTT usually is enough. But for sure, you need early recognition of this problem or early adjustment of the protocols in the ICU.